Dear Chairman, dear ladies and gentlemen, first of all, I would like to thank you for the opportunity to present the European Task Force on Medication-Related Osteonecrosis of the Jaw and our respective work in the field for the past years. The European Task Force of Medication-Related Osteonecrosis of the Jaw was founded by Martin Schett as an international group of experts for medication-related osteonecrosis of the jaw from Italy, Germany, Great Britain, Switzerland, Scandinavia, and Greece. And we met each other in an international conference and workshop in 2018 and 19 in Copenhagen. And ever since, we had multiple online meetings, which were very fruitful, and we are mainly dealing with some of the challenges and controversies of the current literature and the current international guidelines. And our aim is to present a European consensus statement on prevention and treatment of medication-related osteonecrosis of the jaw. The most widely used definition of MRONJ was provided by the AOMS and updated in 2014 and 2022 as exposed necrotic bone or bone that can be probed for more than 8 weeks under ongoing or previous intake of anti-resorptive drugs, namely bisphosphonates or denosumab, or anti-angiogenic drugs, with no irradiation of the head and neck area and no obvious metastases. The AOMS also provided a staging system ranging from stage 0 to stage 3, stage 1 being asymptomatic bone exposure, stage 2 symptomatic bone exposure, and stage 3 bone exposure with complications, stage 0 no bone exposure. However, regarding the definition, stage 0 is not included in the definition but is part of the staging system, and there is no influence of the extent and localization of the lesion. Also, the definition of the staging is not really clear and concise in some of the cases. So our key statements regarding definition and classification is that the current definition of MRONJ does not identify all of the patients. The description of stage 0 is controversial and difficult to interpret, and stage 0 is a diagnostic challenge, and it can be mixed up with other dental and non-dental diseases. Also, the 8-week criterion may delay diagnosis and consequently treatment. And the role of imaging needs to be clearly defined in diagnosis versus staging. So the present classification system does not adequately reflect the disease extension and severity, and therefore it may be problematic to base treatment decision on this staging. Also regarding imaging, there are some controversies. Some authors recommend the clinical diagnosis combined with panoramic radiograph, where you can see sclerosis of the surrounding area, but also osteolytic areas, sometimes persisting alveoli, and also sequestrum formation. However, in some cases, a three-dimensional imaging might make sense regarding diagnosis, but also regarding treatment planning, including cone beam CT, CT scan, and sometimes even MRI. Can identify sequestrum formations, maxillary sinus involvement, but also pathological fractures of the mandible. There is also a lot of controversies regarding tooth extractions and anti-resorptive drugs. It is well known that the majority of MRONJ cases manifested after tooth extractions. So therefore, for some authors, tooth extractions are considered to be local risk factors, or by some authors even believed to be trigger or causative events. So some recommendations recommend to avoid tooth extractions. At least there is a considerable uncertainty among oral and maxillofacial surgeons. However, research has shown that tooth extractions can be performed quite safely, even in case of anti-resorptive treatment, when prophylactic measurements are respected, including antibiotic prophylaxis, smoothing of sharp bony edges, and plastic wound closure. Of course, the wounds tend to delay towards delayed mucosal healing and also delayed alveolar remodeling. So our key statements regarding tooth extractions are that tooth extractions do not automatically translate into an increased risk of developing MRONJ, and the reported high risk of MRONJ after tooth extraction may be related to underlying dental infections, especially marginal but also apical periodontitis. And in general, tooth extractions can safely be performed, including preventive measures. Also, regarding the treatment of medication-related osteonecrosis, there have been a lot of new developments in the past 10 to 15 years. Initially, a lot of authors and guidelines recommended non-surgical treatment algorithms. However, they turned out to be quite unpredictable and associated with a quite low success rate, especially in patients with metastatic bone disease and oncological dosing of anti-resorptive drugs, especially when it comes to nitrogen-containing bisphosphonates with the long half-life. Whereas surgical treatment has shown consistent high success rates and a quite predictable outcome, and also a predictable time frame of treatment. So this is one of our prospective clinical trials, including 54 patients, that showed that with antibiotic treatment, removal of necrotic bone areas, in this case in a fluorescence-guided manner, smoothing of sharp bony edges and a plastic wound closure leads to complete mucosal healing in the majority of patients, in this case 87% after first surgery. Therefore, our key statements regarding treatment are that as there is no accurate staging system, it is quite problematic and potentially even misleading to use a staging system to inform treatment recommendations. We recommend to use clearly surgical or non-surgical treatment regarding the wording, and literature shows that surgical treatment is superior to non-surgical treatment, promoting long-term mucosal healing. So if the aim of treatment is reduction of symptoms, non-surgical treatment might be appropriate, or in frail elderly patients or end-of-life settings. But generally, early surgical intervention on localized disease may prevent progression and the need for subsequent extensive surgeries. So hereby, I would like to thank you for your time and attention, and I think we all hope that at the end of the day, our task force work will lead to a European consensus statement that really can inform the treatment of patients suffering from MRONJ. Thank you very much.